Imagine lying on a hospital gurney, like right before a procedure. You're staring up at those bright ceiling lights, and you glance over at the surgeon's chart.
Oh, yeah. That terrifying moment of waiting.
Right. And one single letter typed on that page basically dictates whether you go home tomorrow with just a small scar or, you wake up with your internal anatomy like permanently rewired.
Well, it's because we expect medicine to be super precise. We want it to be like an engineering project.
Exactly. You break a bone, the doctor points to the x-ray and says, there's the problem, here's how we fix it. But we've been going through these surgical history notes and medical terminology guides, and we realized that two of the most common surgical terms actually mean completely opposite things.
And they sound almost exactly the same, which is the crazy part.
They really do. So today, we're doing a deep dive into these two easily confused suffixes, otomy, spelled with an O, and ostomy, spelled with an OS. We want to give you, the listener, basically a cheat code to read any medical chart.
I love that. Because adding that one single S, it fundamentally changes everything. The stakes of the procedure, the recovery timeline, your actual anatomy.
Right. The difference is monumental, which is why we are on this mission today to break this down. So whether you're, studying for a nursing exam or trying to decipher a relative's chart, or you're just incredibly curious, you are in the right place.
For sure.
Let's just strip away the jargon right off the bat. What is the actual difference when we say otomy versus ostomy?
Okay, so the foundational rule here, and this is what you really have to remember, it comes down to permanence. An otomy means cut and close. An ostomy means cut and leave open.
Cut and close versus cut and leave open.
Yeah.
Got it.
Yeah, and to really grasp why they operate so differently, we have to look at the classical Greek roots. So otomy comes from the Greek word tome.
T-O-M-E, right?
Yes, exactly. Which basically just translates to a cutting or an incision. So when a surgeon attaches otomy to a root word, usually the body part they're operating on, they're making a surgical cut into that structure just for temporary access.
Like they just need to get in, fix the problem, and get out.
Right. They need to relieve pressure, take something dangerous out, whatever. But the key is, once the task is done, they suture that incision right back up.
So the cut is just the vehicle. Nothing permanent is left behind once you heal.
Exactly. Ostomy, on the other hand, comes from a completely different Greek word, stoma. And stoma translates to mouth or opening.
Okay, so an ostomy is?
It's the surgical creation of a standing, permanent, or at least semi-permanent opening. The surgeon is actively modifying the body's architecture.
They're building something new.
Right. They might be connecting an internal organ to the outside of the body, or they might even reroute two internal organs to connect directly to each other.
Okay, so I was trying to visualize this earlier, and I kept coming back to the idea of a camping tent.
Oh, I like where this is going.
Right. So an otomy is basically like unzipping the front flap of your tent because you forgot your sleeping bag inside. You unzip it, reach in, grab what you need, and then zip it right back up.
You just needed temporary access.
Exactly. But an ostomy, that's a massive structural change. It's like taking heavy-duty scissors, cutting a huge hole in the nylon wall of the tent, and installing a permanent window or a new doorway.
Because you need that new opening to function continuously from that day forward.
Yeah.
Yes, that perfectly maps onto the actual surgical applications.
It really clicked for me.
Well, let's apply that tent zipper to the human body. Think about laparotomy, which is a major incision into the abdominal wall, or a craniotomy.
Which is cutting through the skull.
Right. In a craniotomy, a neurosurgeon might be going in to clip a dangerous aneurysm. They need access to the brain, but the moment that aneurysm is secured, they replace the bone flap, and the scalp is stitched shut. The opening was not the goal. It was just the doorway.
But if a patient undergoes a tracheostomy, the calculus totally changes.
Entirely.
Yeah.
In a tracheostomy, the surgeon creates a hole in the trachea, the windpipe, and usually inserts a tube to keep it open. In this scenario, the opening itself is the therapeutic endpoint.
Because the patient physically requires a new, durable airway to breathe. They need a hole that stays open.
Exactly.
Okay, but cutting a permanent hole in a nylon tent is pretty easy. Doing that to a human stomach or intestine, historically, wouldn't that just be a guaranteed death sentence, like from infection?
Oh, absolutely.
It makes me wonder why we even have these two separate classical Greek words. Like, why did modern medicine organize itself this way instead of it just saying, windpipe hole?
Well, the timeline of when these words became standardized is actually heavily tied to that exact problem of survivability. These suffixes, they weren't just cooked up in a modern lab.
Right.
They filtered into Western medicine during the Renaissance and the Enlightenment. Surgery was going through this profound identity crisis in the early 18th century.
Trying to distance itself from the old barber surgeon days, right?
But
Where the same guy cutting your hair would amputate your leg with a dirty saw.
exactly, and usually with the same tools. The medical field desperately wanted the same, classical linguistic rigor that botany and anatomy already had.
Kind of like Carl Linnaeus naming all the plants and animals.
Precisely. And a key figure in this for surgery was Lorenz Heister, a German surgeon who published this massive textbook called Chirurgy in 1718. His work really helped formalize this Greek and Latin vocabulary across European medical schools.
Okay, that explains the language origin. But getting back to the survivability thing, humans have been cutting each other open in wars and primitive medicine for thousands of years.
Yeah, unfortunately.
So why did the term ostomy, the permanent opening, only really gain mainstream traction so much later?
Well, the suffix otomy has actually been documented for over 2 millennia. You can find it in the ancient texts of Hippocrates.
Wow, really?
Yeah, because tome, the cut, was an everyday reality. If a physician in ancient Greece or medieval Europe faced a trauma patient, their only option was to make a cut, pull out the arrow or whatever, and frantically close it back up to prevent the patient from bleeding out.
Right, you had to close it immediately.
But creating an ostomy, an intentional functioning diversion, that functional need couldn't drive the word into wide use until the 19th century, because before that, leaving an open diversion in the body was almost universally fatal.
Because you couldn't just leave an open wound connecting the bowel to the skin before the germ theory of disease.
Right, the patient would just succumb to sepsis almost immediately.
Which makes the historical anecdote we found even more shocking. There is this documented case of a French surgeon, Henri Pilor.
Oh, this case is astonishing.
Yeah. In 1776, he performed a successful colostomy on a patient who had a completely obstructed bowel from a tumor.
And just to put that into perspective for everyone.
Right. 1776 is way before general anesthesia was introduced in the 1840s. And antisepsis, like Joseph Lister or Louis Pasteur, washing their hands and sterilizing tools, that didn't become standard until the 1860s.
Decades later.
And Pilor physically cut into a patient's abdomen, identified the bowel, and created a permanent diversion to the skin. And the patient was completely awake for the entire thing.
It's just
Yeah.
the sheer mechanical skill and speed required to pull that off is hard to even overstate. We tend to view ostomies as these highly sterilized high-tech interventions,
For sure.
but the mechanical concept of the colostomy was being pioneered in the late 1700s. It just took until the 19th century for the standardized terminology to solidify, clearly separating the temporary otomy from the permanent ostomy.
Okay, let's bring this into the modern hospital. Because we've established that the terminology evolved to describe survival procedures, I want to look at how these suffixes are applied to the exact same organs today.
Right, which introduces a crucial second principle in medical terminology.
Yep.
The naming convention follows the organ,
Meaning.
meaning the exact same anatomical structure can appear in both the otomy and the ostomy families. The word you use depends entirely on the surgeon's mechanical intent. Let's look at the stomach, which uses the Greek root gaster.
Okay, so if a patient swallows something dangerous that they can't pass naturally, like a battery or a giant coin, and the surgeon has to go in and retrieve it, that would be a gastrotomy.
Correct. The surgeon makes an incision through the abdominal wall into the stomach, the gastrotomy. They extract the foreign object, or perhaps they're removing a bezoar.
Wait, a bezoar? Like the magical hairball they use for antidotes in Harry Potter?
Surprisingly, yes. It is a very accurate comparison. In human medicine, a bezoar is a solid mass of indigestible material hair, plant fibers, certain medications that just gets trapped in the stomach.
That's so gross. But okay, so they do the gastrotomy, physically remove that mass, and then meticulously suture the stomach and abdomen closed. Anatomy goes back to normal.
Exactly. But now consider a patient with a severe neurological condition who completely loses the physical ability to swallow food. They need long-term nutritional access.
Right, they need a permanent window. The tent flap stays open, so that requires a gastrostomy.
Yes, a gastrostomy creates a lasting, maintained opening directly into the stomach. And today, the most common application of this is something called a PEG tube.
PEG, percutaneous endoscopic gastrostomy.
The PEG tube was revolutionary. It was developed in 1980 in Cleveland by a pediatric surgeon, Michael Gotterer, and a gastroenterologist, Jeffrey Ponsky. And what makes it a textbook example of modern medicine is that it proved an ostomy doesn't even require a massive, open surgical incision anymore.
Wait, how does that actually work mechanically? If you aren't cutting the abdomen wide open, how do you install a permanent feeding tube?
They do it endoscopically. The physician passes a long, flexible camera, the endoscope, down the patient's throat and into the stomach.
Oh.
Then they shine a really bright light from the tip of the camera inside the stomach, and it actually illuminates the skin on the outside of the patient's belly.
Oh, wow.
Yeah, it shows them exactly where the stomach is pressed right up against the abdominal wall. Then they just make a tiny needle puncture from the outside in, snare a wire, and essentially pull the permanent feeding tube down through the mouth and out through that tiny hole.
That is incredibly elegant. It's totally minimally invasive. The exact same organ as the gastrotomy, the exact same Greek root, but a completely different clinical reality.
Exactly.
But let me jump in here with a huge misconception I had. Before we started researching this, whenever I heard the word ostomy, I just instantly pictured a visible external bag attached to the patient's skin, like a colostomy bag. Does the Greek word stoma, the mouth, always imply an opening to the outside world?
No. And that is easily the most widespread misconception, even among early medical students. Because the colostomy, the bowel-to-skin aversion, totally dominates the cultural conversation.
Right, it's what you see in media.
But structurally, many ostomy procedures are entirely internal. They act as a permanent bridge connecting one internal organ directly to another with absolutely no opening on the skin.
So the mouth is just a newly engineered doorway between two organs inside the dark of the abdominal cavity.
Let's look at a gastrojejunostomy. The surgeon cuts a hole in the stomach and surgically joins it directly to the jejunum.
Hold on, let's pause for a quick anatomy check on the jejunum. We're talking about the small intestine, right?
We are. The jejunum is the middle section of the small intestine. By connecting the stomach directly to it, the surgeon intentionally bypasses the duodenum, which is the very first section of the intestine.
And that rerouting is the core mechanism of Roux-en-Y bariatric bypass surgery.
It is the defining feature of that weight loss surgery. It's also used in reconstructive procedures after stomach cancer. Or consider an even more complex internal connection, the colostomy.
Okay, you have to break that one down for me.
So this is often performed during a Whipple procedure, which is this massive, complex surgery typically done to remove pancreatic cancer. The surgeon removes the head of the pancreas, the gallbladder, parts of the stomach and intestine.
Which is a huge amount of tissue.
It is. And after all that is removed, they have to rebuild the digestive tract. A colostomy is the surgical creation of a permanent connection between the common bile duct and the jejunum.
And in all these cases, there is no external bag at all.
None. The suffix ostomy simply tells the medical team that a permanent artificial connection was engineered between two structures.
Yeah. The rules are incredibly logical when you sit down and analyze them. Cut and close versus cut and leave open. Internal connections versus external diversions. But hospitals are chaotic, high-speed environments. What happens when these carefully categorized terms collide with just everyday clinical slang?
Oh, that's where the debate shifts from scientific anatomy to practical linguistics. And the most dangerous example of this clinical drift, the one that causes the most confusion on hospital floors, is the airway dilemma. Tracheotomy versus tracheostomy.
The famous trach.
Yes.
Yeah.
Walk into any intensive care unit and you will hear doctors, nurses, and respiratory therapists simply say, trach. The patient has a trach. We're going to track the patient.
Which blurs the lines between the initial surgical incision and the final maintained opening.
Completely blurs.
Even though we know historically and mechanically they're distinct. I was fascinated by the story of Chevalier Jackson in our research. He was a laryngologist in the early 20th century who actually standardized the safe tracheotomy technique.
His work was a watershed moment in emergency medicine because before Jackson, emergency airway surgery was incredibly crude and carried this horrific mortality rate.
Doctors in a panic would often just slash at the throat, right, accidentally severing major blood vessels or cutting into the thyroid gland.
Exactly, it was a mess. But Jackson meticulously mapped out the safe anatomical entry point, standardizing the precise incision the tracheotomy needed to save a life without causing fatal collateral damage.
So emergency medicine historically distinguished the tracheotomy, which might literally be a temporary emergency slit made in the field with a pocket knife to let a choking person breathe, from the tracheostomy, which is the planned, surgically reinforced, tubed opening you see in ICU patients.
The distinction is mechanically profound.
But I have to ask, language evolves organically all the time. If the ICU nurses and the attending physicians all know what they mean when they say trash in the hallway, does it really matter if they use the formal terms interchangeably?
Well, the real-world consequences are severe enough that major medical style guides, like the AMA Manual of Style, strictly enforce the difference. The first major consequence is patient safety and clinical documentation.
Because if a patient's airway suddenly collapses in the middle of the night.
The responding team needs to know exactly what they're dealing with. If they look at a chart and it says the patient had a temporary emergency slit, a tracheotomy, versus an established, stable, surgically matured opening, a tracheostomy, it instantly changes their life or death management priorities.
So precision in the chart is a direct matter of patient safety.
Yes.
And the second consequence we found is entirely bureaucratic, but honestly just as messy: the financial and coding side of American healthcare.
Right. The U.S. medical billing system runs on procedure codes, known as CPT codes. And these codes distinguish between an otomy and an ostomy, with absolute rigid mechanics. They're treated as entirely different surgical procedures.
Carrying different reimbursement rates, different anesthesia requirements, different risk profiles. So paint a picture for me. A doctor performs a permanent gastrostomy to place a feeding tube, but they are in a rush and dictate their notes using casual slang. Or they accidentally write gastrotomy on the official chart. What actually happens?
It initiates a massive administrative headache. The hospital's medical coding department reviews the chart, sees gastrotomy, and tries to bill for a temporary cut and close procedure. But the operative notes mention a permanent feeding tube.
So it triggers a mismatch.
A huge CPT code mismatch. The insurance company flags the discrepancy and denies the claim. Then the coding department has to query the physician, asking them to formally amend their documentation.
Which takes forever.
And beyond the delayed payments, it legally misrepresents what was physically done to the patient in their permanent medical record.
It is wild that a single misplaced English suffix, just born out of casual hallway shorthand, cascades into legal misrepresentation and insurance denials.
It's the butterfly effect of medical terminology.
So true. Before we finish up, I want to take our two main characters today, otomy and ostomy, and place them in their broader surgical family tree. If we really want to give you, the listener, the cheat code to read a surgical chart, we need to cover a few other common terms.
Okay, let's do it. The nomenclature acts like a mechanical toolkit. We know otomy cuts in and ostomy leaves open. But what if the surgeon takes the structure out completely? That is an ectomy, from the Greek ectoma, meaning cutting out.
Like an appendectomy or a tonsillectomy?
Or a gastrectomy, where part or all of the stomach is physically removed. Then you have plasty, derived from placene, meaning to mold or shape. This indicates surgical reshaping or reconstruction without necessarily removing the organ or leaving a new permanent opening.
Like a rhinoplasty, which is a nose job. They're going in, reshaping the cartilage and bone and closing it back up.
Exactly. Or a pyloroplasty, where the surgeon widens the lower part of the stomach so it empties easier. Often, a surgeon performs an otomy just to get inside, and then they perform a plasty to remodel the tissue while they're there. You also see terms like pexy for fixation, where a floating or detached organ is surgically anchored back into its proper place.
I used to assume, before looking at this research, that because an ostomy leaves a permanent hole in the body, it must inherently be a massive, life-altering trauma compared to a simple otomy cut. Like, I assumed the suffix dictated how dangerous the surgery was.
That is a very common myth, and it is entirely false. The suffix strictly encodes the anatomical permanence of the opening. It tells you nothing about the surgical risk or severity.
Interesting.
Yeah, think about a craniotomy cutting into the skull to operate on the brain. That's an otomy, and it is one of the most massive, high-risk procedures in medicine. Meanwhile, placing a peg tube for feeding is an ostomy, and as we discussed, it can be a relatively quick, minimally invasive procedure done right at the bedside.
Right, that totally flips the assumption on its head. There's another major myth that ties into that fear, too. The idea that if you get an ostomy, like a colostomy, it is a guaranteed lifelong sentence. The tent is permanently ruined.
Also false. The suffix describes the anatomy of the opening at the exact moment the original surgery is completed. It simply means the surgeon purposefully did not close the opening right then, but many ostomies are intentionally temporary.
Like giving the body time to heal.
Exactly. If a patient suffers severe bowel trauma or a massive abdominal infection, the surgeon might create a temporary colostomy to divert waste and give the downstream tissue time to heal. Months later, once the inflammation is gone, the surgeon goes back in, reconnects the bowel, and closes the abdominal wall.
So it's totally reversible.
In surgical terms, this reversal is called a takedown. The opening was an ostomy, but it wasn't a lifelong sentence.
That is incredibly empowering information. And that really grounds this entire discussion for you, the listener. Think about the real-world applications of this. Maybe you are a caregiver managing home enteral feeding for a loved one via a peg tube. Maybe you're staring at a relative's chaotic medical chart after a scary emergency room visit, trying to understand what the surgical team just did. Or maybe you're a student grinding through flashcards for your medical boards. Understanding the mechanical difference behind this one single letter gives you clarity. It gives you control over your own healthcare journey.
It strips away the intimidation factor. You realize you aren't just hearing scary ancient Latin and Greek words. You're hearing a highly specific, logical set of mechanical instructions about exactly what was modified in the human body.
Let's recap the golden rule one last time so it permanently sticks in your memory. Otomy cuts and closes. Ostomy cuts and keeps open. It is the difference between unzipping the tent to grab your sleeping bag and cutting the wall to install a new window.
Looking forward, though, understanding these ancient roots raises a deeply provocative question. These terms were standardized during the Enlightenment. They were codified in an era when the very definition of surgery inherently meant physically slicing through human tissue with a steel blade.
Right, the Greek tome, the literal cut.
But the mechanics of medicine are evolving at lightning speed. As hospitals move further into an era of non-invasive focused ultrasound, robotic lasers that ablate tissue without incisions, and cellular-level molecular alterations, what will the medical terminology of the future actually look like?
Wow, yeah.
Will the ancient Greek concepts of tome and stoma survive the next century of medical innovation? Or will we be forced to invent an entirely new linguistic framework for surgeries, where the human body is never actually cut open at all?
That is a fascinating concept to mull over. A future where the words we use to describe life-saving procedures have to fundamentally change because the scalpel itself has become obsolete. We started today by asking how one letter can change the stakes of a surgery, but tomorrow's technology might force us to change the alphabet entirely. Thank you for joining us on this deep dive. Stay curious, keep questioning the mechanics of the world around you, and we'll catch you next time.